Good day, I am Sherilyn Francis, and on behalf of the South Carolina Tobacco Free Collaborative, we welcome you to part one of our Health Equity webinar series. Additionally, we invite you to connect with us at www.sctobaccofree.org. The mission of the South Carolina Tobacco Free Collaborative is to eliminate the toll of tobacco use by providing leadership, guidance, and resources to state and local partnerships. SCTFC's partnerships and coalitions are utilized to address local tobacco issues and to promote positive public health policies at the community level. Our purpose is to provide leadership in the development of state, county, and local tobacco policies, to facilitate meetings of interested organizations and communities, to promote opportunities for current and future organizations to examine research, trends, legislative issues, concerns, and ideas while simultaneously generating solutions, to promote and support advocacy for tobacco-safe communities among the membership at regional, state, and national levels. I now present to you today's webinar entitled Tobacco Use Among Persons with Mental Illness, presented by Dr. Jennifer Dane, postdoctoral scholar, Department of Psychiatry, Medical University of South Carolina. In compliance with ACCME guidelines, the following presenter has no financial or other relationship with the manufacturers of any commercial service discussed in this educational activity. The objectives for today's webinar are to characterize tobacco use among individuals with a mental health condition, to identify tobacco-related comorbidities among individuals with a mental health condition, describe barriers experienced by healthcare professionals that affect their treatment of smoking and tobacco use in individuals with a mental health condition, and to identify tobacco cessation best practices which are effective for individuals with a mental health condition. And now, Dr. Dane.
Thank you, Sherilyn, and good afternoon, everyone. So Sherilyn and the South Carolina Tobacco Free Collaborative invited me here today to discuss with you all the relationship between mental illness and tobacco use. So today's webinar will start with an overview of tobacco use among persons with mental illness. That will be followed by a discussion of the health and economic consequences of tobacco use among persons with mental illness. Then I'll provide a brief overview of tobacco industry marketing specifically to people with mental illness. And then we'll end with a discussion of helping people with mental illness quit smoking. I've also picked out some of the questions that were sent in prior to today's webinar, and I will work to answer those at the end of the presentation today, time permitting. You can also send in additional questions to me through the webinar using the presenter Q&A pod, and I will try to answer those throughout where appropriate, or we'll also try to get to them at the end. So let's jump right in. So starting with a description of tobacco use among persons with mental illness. So approximately 18% of adults in the US have some form of mental illness, and this equates to more than 44 million adults in the US who are currently living with a mental illness. Now, importantly, there are a couple of groups that are left out of this 18% prevalence rate. So first, this number does not include adults with substance use disorders. So when adults with substance use disorders are included in this prevalence rate, the prevalence of mental illness among adults in the US jumps to 25%. This prevalence rate also doesn't include individuals who are living with sub-threshold psychological symptoms that do not meet criteria for a full disorder. And we know that sub-threshold psychological symptoms are prevalent and cause similar levels of impairment as full-blown disorders. So for example, if we consider depression, in order to meet criteria for a current major depressive episode, someone has to endorse 5 symptoms of depression. But what happens when someone is endorsing 4 symptoms or 3 symptoms? So adults with sub-threshold depressive symptoms have a considerable economic cost in terms of their healthcare costs. And then these sub-threshold depressive symptoms also increase the risk for developing full-blown major depression. And individuals with sub-threshold depressive symptoms have similar mortality rates to those who have major depressive disorder. So this is another important group that we don't really see in this 18% prevalence rate. Now, in terms of access to treatment for persons living with mental illness, SAMHSA reports data on mental health treatment access among persons with mental illness. So, on average, between 2010 and 2014, in South Carolina, 44% of adults with any mental illness received mental health treatment and/or counseling, which is similar to the national rate of 42.7%. This means that in South Carolina, between 2010 and 2014, approximately 281,000 adults with mental illness received mental health treatment each year. However, this also means that more than half of adults with mental illness in South Carolina are not receiving treatment, which highlights the need to increase access to evidence-based mental health treatment both in South Carolina and nationally. Now, once individuals receive mental health treatment in the public mental health system, the majority report improved functioning, which you can see on the right-hand side of the screen here. Now, in South Carolina in 2014, 68.4% of those who received mental health treatment from the public mental health system reported improved functioning, which was comparable to the national average from that time of 70.9%. So if we can get persons with mental illness into treatment, they are likely to report improved functioning. Although only 1/4 of adults in the US have a mental illness or substance use disorder, these individuals consume almost 40% of cigarettes smoked by adults in the US. Smoking rates are significantly higher among people with psychopathology as compared to the general population. So people with psychiatric disorders such as depression, schizophrenia, anxiety disorders, and bipolar disorders smoke at shocking levels. In many ways, this is a hidden epidemic that has serious consequences for the physical, psychological, and financial health of this vulnerable population. Neurobiological, psychosocial, and systems level factors have been identified as contributing to the elevated rates of smoking among persons with mental illness, including the reinforcing or mood altering effects of nicotine, shared genetic factors, and reduced coping for cessation. People with mental illness are also more likely to have stressful living conditions, be low income, and lack access to health insurance, health care, and help quitting. And these are all factors that make it more challenging to quit and lead to heightened smoking prevalence among this group. Now, presented on screen are data from the 2010-2013 National Epidemiologic Survey on Alcohol and Related Conditions. These are adjusted odds ratios of 12-month DSM-5 nicotine use disorder and other comorbid psychiatric disorders. So I want to draw your attention to the column outlined with a red box. Here you'll see the prevalence of past year nicotine use disorder combining mild, moderate, and severe nicotine use disorder among individuals with comorbid psychological disorders. So as you can see, as compared to individuals without nicotine use disorder, those with past year nicotine use disorder are significantly more likely to meet criteria for a host of mental health disorders, including substance use disorders, mood disorders, anxiety disorders, borderline personality disorder, and antisocial personality disorder. Now, as you can see outlined in the blue box, in general, likelihood of meeting criteria for a psychological disorder increases as severity of nicotine use disorder increases. So for example, individuals with moderate nicotine use disorder are 1.31 times more likely to meet criteria for a mood disorder as compared to individuals without nicotine use disorder, whereas individuals with severe nicotine use disorder are 1.87 times more likely to meet criteria for a mood disorder. So then, how does smoking prevalence among persons with mental illness compare to that of other tobacco disparity groups? So here are data from a paper by Williams and colleagues that put together prevalence rates across various groups from a host of nationally representative surveys. As you can see, they report that smoking prevalence among those with mental illness is around 40%, and smoking prevalence among those with substance use disorders is 64%. We then can compare this to smoking prevalence of other groups known to have high smoking rates, such as those that live at or below the poverty line, who have a smoking prevalence between 31 and 37%, or those with less than a high school diploma who have smoking prevalence between 29 and 32%. So smoking prevalence among adults with mental illness is similar to or exceeds smoking prevalence rates of other established tobacco disparity groups. Among adult smokers with mental illness, we see similar disparities that are observed in the general population of smokers. So adults with mental illness who are younger, male, less educated, and live below the poverty line are more likely to be smokers. In terms of racial ethnic differences, American Indian or Alaskan Native adults with mental illness are most likely to smoke as compared to other racial ethnic groups. Now, in the bottom right-hand corner of the screen, you'll see this map that demonstrates cigarette use among adults with any mental illness by state. So here we can look at how South Carolina compares to other states in terms of smoking among adults with mental illness. And South Carolina falls in the group of states that have somewhere between 40 and 44% of adults with any mental illness who are smokers. And this means that South Carolina is among the states with a higher prevalence of smoking among adults with mental illness as compared to many other states. So now we'll move into talking about the health and economic consequences of tobacco use among persons with mental illness. So over 7,000 South Carolinians die each year from tobacco use, and for every one person who dies, another 20 will suffer from at least one serious tobacco-related illness. In South Carolina, 6,300 people become new daily smokers each year, and 240,000 are exposed to secondhand smoke in their homes. The effects of this rampant tobacco use are staggering, and tobacco use is not an equal opportunity killer. Persons with mental illness or substance use disorders die about 5 years earlier than those without these disorders, and persons with serious mental illness die a full 25 years earlier than the general population. As compared to the general population, for example, people diagnosed with schizophrenia face double the risk of death due to cardiovascular problems and triple the risk of respiratory disease and lung cancer. Smoking may also interfere with many prescription medications commonly used to treat mental illness by reducing the therapeutic blood levels of certain psychotropic medications, thereby undermining their effectiveness and prolonging psychological symptoms. The increased morbidity and mortality associated with mental illness is due in large part to treatable medical conditions that are associated with modifiable risk factors such as smoking, obesity, substance use, and inadequate access to medical care. 480,000 people die annually from cigarette smoking, and 42% of these deaths are persons with mental illness. Remember that persons with mental illness comprise about 18% of the US population, so they are certainly overrepresented in tobacco-related mortality. Now, on the right side of this screen, you'll see data from a population-based data set in Oregon that identified persons who received publicly funded mental health or substance abuse services between January 1996 and December 2005. Bandiera and colleagues matched these individuals to the Oregon Vital Statistics records in order to ascertain cause of death. In the general population, 30.7% of deaths were deemed tobacco-related, as compared to 53.6% among those with substance use problems and 46.8% among those with both mental health and substance use problems. As you can see here, persons receiving substance abuse treatment alone or receiving both substance abuse and mental health treatment were more likely to die and more likely to die prematurely of tobacco-related causes as compared to the general population. Persons receiving mental health services alone were not more likely to die of tobacco-related diseases, but tobacco-related deaths occurred earlier in this population. Smokers with mental illness are financially burdened by continuing to smoke. On the left here are data from Steinberg and colleagues who reported on the financial burden associated with smoking shouldered by smokers with schizophrenia. Steinberg and colleagues found that smokers with schizophrenia spent almost 30% of their public assistance income on cigarettes. This results in further limiting their already limited financial resources. For comparison, the average American spends 30 to 40% of their income on housing, and this study suggests that smokers with schizophrenia are spending a similar proportion of their income on smoking. 32% of adults living below the poverty line are smokers. One of the most effective approaches for reducing smoking prevalence on the population level is to increase tobacco taxation, But what effect does this increased taxation have on smokers with mental illness who are also highly likely to be low income? On the right are data from Farrelly and colleagues, who use data from New York, which has high cigarette taxes, and from national adult tobacco surveys to estimate how smoking prevalence, daily cigarette consumption, and share of annual income spent on cigarettes varies by annual income. Despite high tobacco taxation, low-income smokers in New York had similar average daily cigarette consumption as low-income smokers in the United States as a whole. Thus, cigarette excise taxes impose a significant financial burden on low-income smokers in New York State. Farrelly and colleagues found that in New York, smokers earning less than $30,000 per year spent 24% of their income on cigarettes, as compared to 14% of income, which is spent by smokers earning less than $30,000 per year in the US as a whole. Remember, many of these low-income smokers have comorbid mental illness. Thus, high cigarette taxes impose a considerable burden on low-income smokers with mental illness who may be less sensitive to the price of tobacco. Now, turning to the economic burden of tobacco use among persons with mental illness, in the United States, smoking-related illness costs nearly $300 billion annually, including costs for both direct medical care, lost productivity, and lost productivity due to secondhand smoke exposure. Although these healthcare costs are descriptive of all smokers, it's important to remember that persons with mental illness consume 40% of all cigarettes consumed in the US annually, so they can contribute considerably to the economic healthcare burden of smoking. For South Carolina specifically, smoking costs the state over $2 billion in annual healthcare costs. So now we'll move into a discussion of tobacco industry targeting of people with mental illness. So in a landscape in which tobacco companies are losing their foothold with the general public, selling cigarettes to people with psychopathology represents a huge market. The approximately 175 billion cigarettes sold each year to people with psychiatric disorders earn tobacco companies approximately $39 billion annually. The tobacco industry historically has used multiple strategies to market cigarettes to populations with mental illness, and this includes developing relationships with and making financial contributions to organizations that work with mentally ill patients. On the right-hand side of this screen, you'll see some documents from the tobacco industry. Two of these documents are a marketplace description and a purchase order demonstrating how the tobacco industry cultivated these relationships with psychiatric treatment centers. The tobacco industry funded research to foster the myth that cessation would be too stressful because persons with mental illness use nicotine to alleviate negative mood or to self-medicate. The tobacco industry provided free or cheap cigarettes to psychiatric facilities. One example of this is the document that's on the right-hand side of the screen that was written from the executive director of a mental health treatment center to a tobacco industry representative requesting free cigarettes to be placed in the stockings of patients for Christmas. And the executive director of this treatment center writes that it would be nice for the patients to wake up and feel like Santa had come over the night. The tobacco industry supported efforts to block smoke-free psychiatric hospital policies and created marketplaces that targeted marginalized populations. And this includes the mentally ill, the homeless, and LGBT individuals. One example of this is Project SCUM, which stood for Subculture Urban Marketing, which was implemented in San Francisco in the 1990s. There's a link on the bottom of this screen to a recent video that you might have seen advertised by the Truth Initiative that I think does a really nice job of highlighting how the tobacco industry has marketed specifically to persons with mental illness. And so if you have time after this webinar, I really would suggest that you watch that. It's only a couple of minutes long. So here are just a few ads that to me appear to be targeted toward persons with mental illness. So you can see the ad that's in the top left of the screen says, "It's a psychological fact. Pleasure helps your disposition. For more pleasure, have a Camel." And so cigarettes in several of these ads are associated with pleasure, feeling better, elevating your mood. There's also an ad in the middle of the screen that shows pairing a cigarette with whiskey, and it says, "I relax with a mild whiskey." So here it's marketing of cigarette and alcohol co-use. And the tobacco industry seems to have kind of boundless money that can be spent on these marketing efforts. And in 2014, tobacco companies spent $1 million an hour every day, 365 days a year, marketing tobacco in the United States. So how can we help persons with mental illness quit smoking? So first, there are a number of myths that abound about helping people with mental illness quit smoking, which I will try to debunk in these subsequent slides. So the first myth is that tobacco is a good self-medication tool for individuals with psychopathology. The second is that persons with psychopathology are not ready, nor are they interested in quitting smoking. The third is that persons with psychopathology are not able to quit smoking while also addressing their comorbid mental health problems. The fourth is that quitting smoking interferes with mental health treatment. And the fifth is that quitting smoking should be a low priority when treating individuals with psychopathology. So to start debunking these myths, so adults with mental illness who smoke want to and are able to quit, but these services may be difficult to access. So in the United States, 20 to 25% of smokers report that they intend to quit smoking in the next 30 days, and another 40% say they intend to do so in the next 6 months. Smokers with psychiatric disorders are about as likely to want to quit smoking as the general population of smokers. Furthermore, among smokers with mental illness, readiness to quit appears to be unrelated to the psychiatric diagnosis, to the severity of symptoms, or the coexistence of substance use. However, despite comparable levels of motivation to quit, persons with mental illness have lower quit rates than the rest of the population. Results from NESARC suggest that persons with a psychiatric diagnosis were 25% less likely to quit than those without a psychiatric diagnosis. While at the population level, persons with mental illness have lower quit rates, studies show they can achieve equal quit rates with access to appropriate cessation services. There have been several Cochrane reviews focused on the efficacy of smoking cessation treatment among persons with mental illness. On the top left of this slide are results from one of these Cochrane reviews among adults with schizophrenia. Results suggested that bupropion, which is an antidepressant medication previously shown to be effective for smoking cessation, helps patients with schizophrenia to quit smoking. The effect was clear at the end of treatment and may also be maintained after 6 months. Patients who used bupropion in the trials did not experience any major adverse effect, and their mental state was stable during the treatment. Varenicline also helps individuals with schizophrenia to quit smoking at the end of the treatment. However, the evidence at the time of the Cochrane review was based only on 2 studies, and it's unclear whether this benefit is maintained for 6 months or more. A similar Cochrane review examined smoking cessation interventions for smokers with current or past depression. Evidence from this review suggests that adding a psychosocial mood management component to a standard smoking cessation intervention increases long-term cessation rates in smokers with both current and past depression when compared with the standard intervention alone. And those forest plots are presented on the screen on the bottom left. Bupropion may also increase long-term cessation in smokers with past but not current depression. Now, this is just a brief overview. There are many studies that have examined smoking cessation among adults with psychopathology. However, as is displayed on the right, few mental health treatment facilities offer smoking cessation treatment. SAMHSA surveys mental health treatment facilities annually to assess the services they deliver, and only 24.2% of mental health treatment facilities in 2010 offered smoking cessation services. Now, to dispel the myth that quitting smoking may have a detrimental effect on mental health, here are results from a 2014 meta-analysis from Taylor and colleagues. This was a meta-analysis of 26 studies that assessed mental health, including anxiety, depression, mixed anxiety and depression, psychological quality of life, and stress. Studies were included that assessed mental health before smoking cessation and at least 6 weeks after cessation or after baseline in both healthy and clinical populations. Standardized mean differences for those who quit as compared to those who continued to smoke are presented. On the left, you can see that anxiety, depression, mixed anxiety and depression, and stress significantly decreased between baseline and follow-up in quitters as compared to those who continued to smoke. On the right, you can see that both psychological quality of life and positive affect significantly increased between baseline and follow-up in quitters as compared to those who continued to smoke. Thus, quitting smoking may have positive effects on psychological well-being. So what can we do? So this is a very text-heavy slide, but I think that there is a lot that we can do as mental health professionals, as policymakers, to try to decrease smoking prevalence among persons with mental illness. So to start, for folks who are mental health professionals, I think the most important thing to start with is assessing tobacco use. So I know that that many participants in today's webinar wrote in with questions ahead of time and expressed concern about the ability to prioritize tobacco treatment when they're seeing patients who have mental illness. And I think the most important first step is to ask the question. So ask your patients who you're treating for mental health comorbidities if they use tobacco, and if they do, then you can help them to quit smoking. And for those patients, offer proven quitting treatments, and this may include tailored quit assistance that is modified to treat both the psychological disorder and the tobacco use. So for example, you might think of tailoring an evidence-based treatment for depression like cognitive behavioral therapy or behavioral activation to also include evidence-based smoking cessation components like setting a quit day, monitoring craving, monitoring number of cigarettes smoked, and using an evidence-based medication to help quit. You should refer your patients to the state quit line, which is 1-800-QUIT-NOW, or to smokefree.gov, and then also provide education around medications to help your patients stop smoking. Quitting smoking in this population should be part of a comprehensive treatment approach. So, smoking does not exist in a vacuum by itself, and you should think about approaching it as part of a holistic treatment approach. And then, like I talked about earlier, mental health medications may need to be adjusted based on whether someone is smoking, and this should certainly be considered on a case-by-case basis, and should be you should approach this using consultation with a team of experts. I know some folks wrote in with questions about how to alter medications for psychiatric problems in persons who are smoking, and I really think it needs to be treated on a case-by-case basis. Mental health treatment facilities should include quitting treatments and quitting programs as part of their treatments that are offered, and practices that encourage tobacco use, like rewarding patients with cigarettes or rewarding patients with smoke breaks, should be stopped. It's also important that assistance is provided to the employees in order to help them quit smoking, because I know many attendees today wrote in and expressed concern about the ability to get buy-in from treatment providers in mental health facilities, and I think a lot of times that resistance might come from the treatment providers being smokers themselves, and when their patients lose smoke breaks or lose privileges related to cigarettes, the counselors also lose those benefits. Mental health facilities should be entirely 100% smoke-free in order to promote quitting in this group. In terms of policymakers, mental health and tobacco control programs really need to work together in order to reduce tobacco use. And on a state level, mental health and addictions agencies should be mandated, and if mandating isn't possible, then very strongly encouraged to put in place tobacco quitting programs and tobacco-free campuses. Policymakers should work to support and sustain evidence-based tobacco control programs. And we can think about ways to try to reach those folks that aren't already engaged in our mental health treatment. So like I talked about at the very beginning, in South Carolina, less than 50% of our adults with mental illness are engaged in treatment. So we need to think about how we can enact policies to support treatment dissemination to those individuals who aren't already engaged in our mental health treatment system. And I think one way to do that is to leverage technology and telehealth to improve access to our tailored smoking cessation treatments. And that's some of the work that we are pursuing here at MUSC. And now for persons with mental illness themselves, the first step is really to decide to quit using tobacco right away and to ask your doctors and your mental health treatment providers for help quitting. So to utilize the resources that you already have at your disposal. The State Quit Line is a wonderful resource. And then it's also important to get support from your loved ones and the folks that you spend time with. So it's important to encourage them to smoke, to quit smoking, and to avoid things like secondhand smoke, which may be related to relapsing.
Thank you very much, Dr. Dane. We are now in the question and answer phase of our presentation. We encourage you to submit live questions. However, we will also be taking questions from your registration, so we'll be fielding both questions. Also, we have Megan and Ian from the South Carolina Tobacco Free Collaborative. They will be sharing in our Q&A section. So question 1.
Great.
I find that patient... Yes, I'm sorry.
Go ahead.
Okay. So question 1. Patients seem to be using tobacco as a means of self-medication for their mental health condition. I also find myself avoiding the topic unless the mental health condition is fully addressed and properly medicated. Are there any other approaches to this type of patient?
So I think that this was a really good question, and I think something that comes up very frequently. So I think the first step in treating mental illness in context with tobacco use is to provide psychoeducation and understand from the perspective of the patient more about the link between mental health and tobacco use. I think there are a number of clinical strategies that can be really useful for trying to get a better idea of this link between mental health and tobacco use. And I think that a good first step is to have the patient start with just self-monitoring, which may actually help to build motivation. So one way, I think Sherilyn mentioned this earlier, but my specific research in clinical areas, it tends to be within depression and tobacco use. So I'll kind of focus on depression and tobacco on that comorbidity as I give some clinical examples. So you could think about a patient that you're treating with comorbid tobacco use disorder and depression, and you might have them start with just monitoring the things that they're doing, their mood, and their tobacco use over the course of a week. And my guess is that many folks will come back and they'll see that their smoking is higher when their mood is worse. And this can really be a useful tool to help promote motivation among these patients by pointing out those links between mental health and tobacco use.
Okay, thank you. We have a question from a participant. Aside from the Quit Line, what other resources are available for smoking cessation?
So I think that there are many resources available for smoking cessation. A lot of good information can be found on the National Cancer Institute's website. You can actually, just on smokefree.gov, if you're a clinician, you can go on and request educational materials that they'll mail to you that you can provide to your patients to get that information out there to them. here at MUSC, we have a comprehensive smoking cessation clinical team. So if you're local in South Carolina and you have someone that is trying to quit smoking and perhaps also has some mental health comorbidities, you could certainly think about referring them to our team here. When we think about technology and using technology to disseminate these treatments, NCI and the National Quit Line also they have several smoking cessation apps that are available that you could think about referring your patients to, and these apps will help your patients with things like setting a quit day, looking at the financial consequences of continuing to smoke, might help them to find locations where they can purchase NRT. In terms of other resources for smoking cessation, I think one of the most important first things to start with is getting someone an evidence-based stop smoking medication. So you can get NRT through the state quit line, depending on the state and depending on the person's insurance status. And it's also available over the counter. You might think about having a patient schedule an appointment with someone who can prescribe varenicline or bupropion. So I think those are all good kind of first step resources.
Wonderful. Speaking of NRT, we have a question here that says, typically patients with mental health conditions are some of the toughest patients to treat because they have multiple medications and they are oftentimes reluctant to try NRTs. So are there any suggestions?
Yeah, I think this is another thing that's also very common and that I've experienced a lot in my clinical practice as well. And I think, again, the most important first step is to provide psychoeducation about what nicotine replacement therapy is. So NRT is the same nicotine that your patient will be getting by continuing to smoke, but it removes all of those other harmful components of a cigarette. So instead of kind of framing NRT as another medication that your patient who's maybe already on a whole host of medications would have to take, I would think about kind of framing it as really harm reduction. So this is something that you're already taking, but we're going to make it better for you. We're going to make it safer for you. And I think that can help to build some buy-in. I think it's also helpful. A lot of times, patients have tried NRT in the past, whether they've tried it when they were in an inpatient facility that restricted smoking, or they've tried it when they were hospitalized, or they tried it on their own. And I've experienced that sometimes patients will have had a negative experience with NRT in the past that can kind of color their perceptions of it now. So I think it's important to talk with your patient about their past experiences using NRT or using other stop smoking medications to understand what happened during those past experiences and how that might affect how they're feeling about the medication now. And really, especially with NRT, the take-home message is that there's really no harm in trying because, it's the same active nicotine that you're already getting by continuing to smoke cigarettes.
Are there any unique linkages for veterans with PTSD and tobacco use?
I'm not really sure that I'm the best person to answer that question about unique linkages in PTSD and tobacco use. What I do know is that smoking rates are certainly elevated among adults with PTSD, whether it's a military involved trauma or not. So I think much of what we've discussed here today would certainly apply for that group.
Okay. How do we best support inpatient mental health clients who do not want to quit smoking or seemingly do not want to quit smoking?
So I think that this is a great question. And I think that there are a lot of things that can be done within inpatient facilities. So inpatient treatment is a great time for patients to try practicing quitting and making a practice quit attempt with assistance, such as with NRT or with other medications for quitting smoking, when the treatment center is 100% smoke-free. I think an important thing to remember in this context is that it's helpful to get the patient to think about this opportunity for quitting as an intentional quit attempt rather than quitting due to the circumstance or quitting because it's mandated. So we know that when smokers quit because they're mandated to, because they're incarcerated or they're in an inpatient facility, and it's not really an intentional quit attempt, there are very, very, very high relapse rates when they leave that environment. So trying to make this experience an intentional quit rather than a mandated and unintentional quit, I think is important.
Would you recommend tobacco cessation or prevention programs for high school students as an after-school activity?
I'm not sure of the current state of the literature on after school or prevention programs for high school students. I I certainly can't see a harm in thinking about instituting a prevention program as an after school activity. And certainly, when I was in graduate school at Maryland, some of the clinical trials that we had ongoing, these weren't with high school students, but they were with students who were just starting college. We modified an evidence-based treatment for depression to target tobacco use and depression, and this was with freshmen and sophomore college students. So I think it's an important avenue for continued clinical trials and thinking about developing and testing and then disseminating tailored interventions targeting mental health and tobacco use in this group of older adolescents.
As public health professionals, we get a lot of pushback when we work with mental health sites that also address other substance addictions. So do you have any suggestions?
Yeah, so I think that this is a really common struggle, and it ties back into some of the misconceptions about quitting smoking and about quitting using other substances at the same time. So counselors in community substance use treatment clinics often believe that quitting smoking while also quitting using other drugs might not be a good idea because quitting smoking may make it harder for the patient to quit using other drugs. And I think that in these instances, the most important first step is to provide as much education as possible to these community substance use providers on the benefits of quitting smoking when quitting using other drugs. Primarily that the likelihood of relapse is decreased when the patient quits smoking, when they also quit using other substances. So, this might be important for a community substance use treatment center if they're trying to reduce their readmissions rates. Then if you want to prevent relapse among your patients to keep them from getting readmitted into your treatment center, then you should also want to help them quit smoking. Because if you help them quit smoking at the same time, then they're less likely to relapse and they're less likely to come back to you. And a lot of times, community substance use treatment centers are graded or evaluated based on their relapse and readmissions rates. So this could be a really important way to get buy-in from those community treatment sites. It's also important to provide these sites with resources like medications to quit smoking that might make it easier for them to promote quitting among their patients. So when I was a graduate student, we were conducting a clinical trial, and this was a depression treatment that was modified for smoking cessation among individuals with substance use disorders. And we were conducting this study at a time when the Community Substance Use Treatment Center implemented a smoke-free policy. And it was wonderful that they went 100% smoke-free, but the downside was that they went 100% smoke-free without having any resources or any medications available to give their patients. So as researchers and clinicians, one of the first things for us was trying to figure out a way to get this clinic medications for their patients who are trying to quit. So one sort of holdover that we implemented was when a patient came in to the treatment center, if they were a current smoker, during their initial intake session, they, with their counselor in the substance use treatment center, made a call to the state quit line in order to get medications to help with quitting smoking. So that's a strategy that could be implemented in other places, as well as possibly partnering with the resources in your area to see if there are ways to get medications for quitting smoking like NRT for your treatment center when you go smoke free. But I think having those resources available from the get-go will be really important in order to build buy-in and to make a smoke-free policy successful.
Phenomenal. So our next question. Are there benefits to electronic cigarette use among persons with mental illness?
Yeah, so I think that this is certainly a rapidly growing area of research, and whether it's an adult with mental illness or someone without mental illness, electronic cigarettes will certainly reduce the harm that someone is exposed to. So I think e-cigarettes are an important tool that should be considered in quitting smoking. So we know that so if you have a patient that's come in, and we can take the case of a smoker with depression that's coming in, and let's say that this is a person that has tried NRT in the past and has failed, and maybe has tried other treatments in the past and they failed. I would certainly think about considering an e-cigarette as a cessation tool because it's certainly less harmful than the cigarettes that the person is continuing to smoke. And I think that research in this population will continue to grow. E-cigarette research among persons with mental illness will continue to grow. But what we know for sure at this time is that they are certainly less harmful than cigarettes. So I would encourage you to consider using them with your patients with mental illness.
Okay. So this is kind of a scenario and a question. What if the individual is living with serious mental illness and they also are suffering from substance use disorder and they say, I can't give up everything. Smoking is all I have left. It helps my anxiety as well as feeding that nicotine receptor. So what do you say to that patient or to that healthcare provider?
So I think that this is, for those of us who do clinical work with this population, I think that this reluctance is something that pretty much every patient will express. And I think the first step is to acknowledge how common that feeling of reluctance and hesitation is. One strategy that I use in my own clinical practice with working with folks to help them quit smoking is, it can feel really overwhelming when, maybe you've been smoking regularly for decades. And to think about kind of going the rest of your life without ever smoking another cigarette, that can be really, really overwhelming, and it would make anyone feel reluctant or hesitant to try to quit. So I think you can take that big goal of being smoke-free forever and break it down into a smaller goal that might feel a lot less overwhelming. So instead of being, having 0 cigarettes for the rest of your life, well, let's think about, what about having 0 cigarettes tomorrow, or having 0 cigarettes for a week? And then, you can take those smaller building blocks and build upon them over time. So I would say, first, acknowledging that it's normal to feel hesitant or to feel reluctant. Perhaps talking with the patient about what past experiences quitting have been like. How was their mental health affected? This is where things like monitoring the relationship between mental health and tobacco use can be really important and can be a really important data gathering tool. So you can see, how does tobacco use change as mental health gets better or it worsens? And you can use that as a strategy to also get some buy-in as well. I would certainly have someone continue to monitor mental health and tobacco use after they try to quit, because I think it's easy, to look back on past quit attempts and to say, oh no, my mental health didn't improve. But in the moment when you're monitoring it, you might actually see that over time your mood or your symptoms do improve. So actually some kind of consciousness or awareness raising with the patient can be important.
Wonderful. Are there any new or novel treatments that are being tested among patients with mental health conditions?
Yeah, so there are many new and novel treatments that are being tested with patients with mental health conditions. We have some ongoing trials here at MUSC. I can talk a little bit about some of my current research. So like I mentioned, my research area is mostly in depression and tobacco use. So our group has developed a couple of mobile apps that are are mobile versions of an evidence-based treatment for depression that's called behavioral activation. And now we are moving in the direction of starting to tailor this intervention to also target smoking cessation. And this is based on some past research from my mentors when I was at Maryland, tailoring this behavioral activation for an in-person delivery for smoking cessation. But like I mentioned earlier, we really need to think about how to disseminate these treatments to folks who might not engage in our traditional mental health treatment system. So things like technology and mobile apps, and then taking that technology and pairing it with stop smoking medications could be a way to get treatment out there. And there are other teams that are also developing technological solutions to disseminating smoking cessation treatments, and other folks here at MUSC who are doing similar things as well.
Awesome. So I have a question for you because e-cig use is very controversial. So what would you say to those health professionals or clinicians who see an electronic cigarette as simply another nicotine delivery system?
Well, an electronic cigarette is another nicotine delivery system, just like NRT is another nicotine delivery system. So it's not about not delivering the nicotine, it's about delivering it in a way that is safer. So I would say, if someone is reluctant to have their patient using nicotine, then I would say, no, then obviously the e-cigarette is not the treatment approach for you to use with your patient. But if you have a patient that's tried lots of other things in the past and has failed, an e-cigarette is safer than a cigarette. It is still a nicotine delivery system, though.
Thank you for clarifying that. So, and this is another scenario question. Since I work with clients on quit attempts, what unique factors do I need to be aware of or change as it relates to my approach, as in the health professional's approach, with regards to this population? So what are some best practices?
So I think that, a lot of us will work with our patients on quitting and on making quit attempts. And I think in terms of tailoring your approach with a patient who has mental health comorbidities, really the most important first step is sort of to tailor your education about quitting smoking to be specific to and relevant to that person's mental health symptoms. So I might start with asking your patient about how their mental health symptoms are related to smoking and how their symptoms have been related to quitting in the past. I might ask about how this has been a problem for the patient in the past. How does their mental health change as a function of continuing to smoke or as a function of attempting to quit? What happened with their past quit attempts, and how was their mental health affected relapsing, or maybe situations where it was more difficult for them to stay smoke-free. So I think kind of the take-home message is just to think about sort of tailoring your approach to education to make sure that you're contextualizing it within the person's mental health symptoms.
Dr. Dane, has your research examined the future of electronic cigarettes, and what do you see as the future, if you were to make any predictions, the future of electronic cigarettes in the United States?
So that is a huge question that I am certainly I'm really not an e-cigarette researcher. So I would say that I think that's a good question, and I would leave it to the folks who are the policymakers and policy researchers to do some forecasting about what the future of e-cigarettes in the United States is.
Thank you. How can physicians, counselors, etc., be reached regarding the importance of quitting tobacco for our clients?
So I think kind of in addition to what's been discussed earlier, I think one of the most important ways of getting engagement from clinical staff who are working with patients is really to provide those smoking cessation services to the clinical staff themselves, because once you get buy-in from the clinical staff, that will carry over to buy-in from the patients. And I think that this is something that's often overlooked. So we know that that, for example, substance abuse counselors who are working in residential facilities, oftentimes they are smokers themselves, and it's difficult to advocate for your patients quitting when you're smoking as well. So I think certainly whatever services are extended to the patients should also be extended to the counselors and the other staff working at the treatment centers. And that's really important to consider when trying to reach these physicians and counselors and other folks that might work in these settings in terms of the importance of quitting smoking for their clients.
Thank you. So we recognize as health professionals that persons with mental health conditions often have more extenuating circumstances which may contribute to relapse. And at times we may question whether or not they are truly committed to quitting tobacco use. So what advice would you give to a health professional in this space? What route or what action should they take?
Yeah, so I think in these um, situations, sometimes it can really be frustrating when you have a patient who's regardless of whether they're a smoker or not, it's frustrating when someone's symptoms get worse. It's frustrating when they lapse or relapse if they're a smoker. And I think in these circumstances, it's important to remember that each patient is an individual. And so we can think of every slip or every relapse really as a learning experience and a way to learn more about what's working for this individual and what isn't working. So, for example, when I work with patients who are trying to quit and who have mental health comorbidities and have slipped, I personally always try to focus on the positive or what the person has achieved in trying to quit, and try to kind of avoid throwing the baby out with the bathwater. So, for example, I was working with a patient who was trying to quit smoking. He also had current major depressive disorder and a past history of cocaine use disorder that was in sustained full remission. And he set a quit day. He was able to go 5 days without smoking before slipping and smoking one. And he was really sort of down on himself when he slipped and smoked one. And one way of looking at sort of the positive in this situation is sort of to ask your patient, well, when is the last time that you went 5 days without smoking? And the last time this patient had done this was over a decade ago. So that's a success, and to focus on what went well and to keep doing whatever's going well, and then see the slip as an opportunity to learn about what's not going well and to change things in the future. And I think that can help to decrease some of those frustrations that we might experience when working with this population.
Dr. Dane, thank you so much for a very informative presentation. It is now 3 o'clock, and I thank each of our participants for attending. And as you'll see at the bottom of the screen, you have today's webinar presentation. Additionally, in the pod next to the presentation, there are some resources which were mentioned during today's webinar. The webinar recording will be made available to all registrants within 24 to 48 hours. And we thank you for your time, Dr. Dane. We thank you again for your expertise, and I hope each of you have a wonderful afternoon.